The immunization guideline updates, specifically the new ACIP guidelines for the pneumonia vaccine, and then also touching a little bit on Ebola. So it's going to be Ebola of information today. Mike made me do a pun, but this guy's a master of puns, so watch out for him. Okay? So the learning objectives for today, can everybody see this? I'll probably stand around here not to block the view. So first we're going to touch on the updated pneumonia guidelines and compare them to the previous guidelines and what changed, what's new, and what is important for our practice in pharmacy. Then I'll be discussing what some of the data was used to support those guideline recommendations from ACIP. And then also reviewing the immunization guidelines for shingles, meningococcal, which is fairly new in New York, as well as for influenza, as these are the ones that we can do in New York State. And then I'm going to reinforce these guideline recommendations using patient case activities towards the very end. And then, of course, last but not least, discussing what the latest developments are on Ebola within the United States, as well as globally, and what its impact is going to be on us as pharmacists. So to start out, pneumonia is going to be the first topic we'll be discussing. It's most commonly caused by a bacterial strain known as Streptococcus pneumoniae. This is one of the most common causes of severe pneumonia cases within the U.S. And it can also cause other types of infections, not just pneumonia. It can cause infections within the ear, sinus infections, as well as another type of infection known as invasive pneumococcal disease. And this can also lead to meningitis, which can be fairly deadly, but these strains other than pneumonia are fairly rare and not as common as the common pneumonia. And the picture there, just for reference, is what a common strain of pneumonia looks like. So at-risk population, as you can imagine, are young children under the age of 2 years of age, anyone with chronic heart, lung disease, asthma, or respiratory dysfunction, and of course, cochlear implant or leaks in the cerebrospinal fluid. And the reason for that is it opens up the brain and that passageway for bacteria to enter and cause infection. And structural deformities can also increase their susceptibility to pneumonia, specifically meningeal pneumonia. Adults 65 years of age or older, as you would expect, as we get older, our immune system ages and becomes weakened and not as able to fight disease. So these patients are at increased risk of pneumonia, as well as anyone between the ages of 19 and 64 who have comorbid conditions. So there's a long list of what these conditions are. They're basically involve chronic heart disease, diabetes, asthma, any type of at-risk for pneumonia disease, as well as smoking. Smoking is also a risk factor for pneumococcal disease, and as you'll see later on, is one of the indications for vaccination. So some of the common symptoms of pneumonia include fever, chills, as you would expect with most common colds, as well as cough, difficulty breathing, and also chest pain due to persistent coughing. And as you can see here, on the left there's normal alveoli, which is free, clear, allows optimal diffusion of gases across the membrane. And then on the right is pneumonia because of the immune response and also the inflammation leads to mucus production and can inhibit, because of the fluid, all of the gas exchange in the lungs. So this can be pretty dangerous for patients who have significant respiratory dysfunction, especially for COPD, patients who are very far along in their disease. It's an irreversible disease, and this can lead to death in some of these patients. It's very important to vaccinate this population. So there are two types of pneumococcal vaccines currently on the market. It's Prevnar 13, which is fairly new, and Pneumovax 23, which has been on the market since 1981. The Advisory Committee on Immunization Practices, commonly known as ACIP, is what referred to as the rest of the presentation, recently revised the guidelines on the pneumonia vaccine. So we'll delve into that because there's a lot of confusion between what these guidelines mean and what its impact is for our patients. So there is a little bit of an overlap. The only strain that Prevnar covers that Pneumovax does not is strain 6A, but all the other ones are covered by Pneumovax 23. Here's a picture of what Prevnar 13 looks like. It comes in as a pre-filled syringe, supplied as 0.5 mL. It's given intramuscularly, and fairly similar to a lot of probably the flu shots that you've seen. Very easy to use. You attach a syringe, inject IM for the patient. Some of the contraindications for Prevnar 13 include a previous allergy or severe allergy to tetanus or diphtheria-containing vaccine. This is a conjugate vaccine. It actually uses a little bit of diphtheria to create the actual protein. So any patient that's had a reaction to a diphtheria-containing vaccine should not get this. And the common contraindications apply. If the person's ever had a previous reaction to Prevnar, they obviously should not get it. So Pneumovax 23 is indicated for any patient at least 2 years of age or older. It's also indicated for 50 years and older, of course. And this covers 23 types, as you would expect. And the ones highlighted in red are the ones that are also covered by Prevnar 13. And as you can see, it covers a fairly extensive list of pneumonia strains. So Pneumovax is supplied as a single dose or multi-dose vial, which can be used for up to 5 doses. It also comes in a pre-filled syringe. So I'm sure a lot of the pharmacists in the room like the pre-filled syringes because it minimizes the risk of needle stick. It's also easier to administer. Pneumovax can be given IM or subcutaneously, though most people probably would just prefer IM since it's more consistent with a lot of the flu shots. There's an interesting thing in their package insert between Pneumovax and Zostavax. So both of these products are marketed by Merck, and there was a study done when Zostavax was being approved that looked at Pneumovax and Zostavax concomitant use, and they found that when these two were given together, the immune response to the varicella virus was actually decreased. So they recommend at least a 4-week interval between these two vaccines. It's not because Zostavax is live and Pneumovax is inactive. It's just based on this trial. They kept it in the package insert. So if you have any questions regarding that, it's usually at least 28 days between them. So here we go. This is what's been confusing a lot of pharmacists lately. So what changed between the old guidelines and the new guidelines? Previously, it was if you got the Pneumovax before you were 65, once you turn 65 and it's been more than 5 years since that previous dose, you would revaccinate them with Pneumovax 23. It's changed now that if they're 65 years and older and they've never had pneumococcal vaccine in the past, so this is known as pneumococcal naive, they would get Prevnar 13, and within 6 to 12 months, they'd be vaccinated again with Pneumovax 23. And you know, if they've had any kind of indications, of course, that would also be an indication for vaccinations. The two vaccines cannot be administered at the same visit. They must be separated by at least 6 to 12 months. There were studies done that looked at immune response as well as immunogenicity and antibody levels, and they found that this was the optimal regimen for those patients. And if, for whatever reason, a patient cannot come back within 6 to 12 months, if they're traveling, if they're going to be away for an extended period of time, you can give it within 8 weeks of each other. That's the minimum interval between the two vaccines. But they should not be given at the same visit. And that's for patients who are 65 and older and have never had any pneumococcal vaccine. So what if they've had previous vaccination with Pneumovax 23? So if they were 65 years and older and they've had at least 1 dose before they were 65, they would get Prevnar 13 as long as it's been more than 1 year since the previous dose, and then if indicated, so if they have a comorbid condition, they have asthma, diabetes, heart, liver, renal disease, anything that would put them at risk for pneumococcal disease, they would get vaccinated again within 6 to 12 months with Pneumovax 23. And I know this is a lot of words, but I have a chart in here that kind of makes this a lot easier to understand. And if they do get a second dose of Pneumovax 23, that has to be more than 5 years since the first dose. So without blurbing on too much, here's a slide from the ACIP guidelines directly. So on the top there, you can see pneumococcal vaccine naive patients aged greater than 65 years, 65 or older. You would give them Prevnar 13 once they turn 65. And then within 6 to 12 months, you give them Pneumovax 23. PPSV is just another way of saying that. And if they've received Pneumovax greater than 65 years old, so if a patient was 66 and now they're 70 years old and they got Pneumovax at 66, they would get Prevnar 13 as long as it's been more than 1 year since that dose. So if they got Pneumovax at 66, they can get Prevnar 13 at 67 or greater, and then that's it. They would be done for the rest of their life, essentially, until they change these guidelines. That's a little caveat there. So if they previously received Pneumovax before they were 65, so for example, some patients may have gotten it when they were 50, when they were 55, now they're 65 and older, what happens with those patients? For those patients, they can get Prevnar 13 at age greater than 65, as long as it's been more than 1 year. So if a person got it at age 55, now they're 67, it's been 12 years since that last dose, they can get Prevnar right away. And if they have an indication, comorbid condition, asthma, diabetes, any sort of chronic condition, they can get Pneumovax 23 within 6 to 12 months. And this Pneumovax 23 has to be more than 5 years since their first dose. So if they got it at 55, they can get this again at 60. But obviously this would be 65, so you already have that covered. It's a little confusing. You want to make sure that you have their timelines correct. It's very difficult sometimes to get an adequate immunization history for a lot of patients. Sometimes patients don't remember what they've had, and we all know it's very difficult to keep track of all this information. But when in doubt, reaching out to the prescriber, the primary care physician, and making sure we have an adequate history before vaccinating. Question?
Clarify this for me, because I got Pneumovax when I was after 60, when I was older than 65. I'm now 80. So, do I have to get another shot, or am I set the rest of my life?
Because of the change guidelines, it's recommended if you've never had any further vaccine than that, just the Pneumovax 23.
I had Zostavax.
You had Zostavax?
Yeah.
Yeah, so basically, actually, that's a perfect candidate, so you would be a candidate for Prevnar 13, since it's been more than 1 year since that last dose. And then if you have any sort of chronic condition, any kind of risk for pneumococcal disease, you get the further revaccination.
So I should be revaccinated?
Yeah, for the new Prevnar 13.
With Prevnar.
So that's the difference. And Prevnar can be given in any pharmacy without a prescription, and a lot of pharmacies now have new collaborative agreements with physicians so that we can administer it freely without having to contact the prescriber at all.
Yeah, thank you.
And the further cases will play more onto this.
On that same note,
Sure.
it's not, anyone under 65 would have never gotten a Prevnar 13, right?
It actually is indicated for more than 50. The other set of guidelines that I didn't go too in depth in this was for patients under 65, those guidelines did not change. So if they're under 65 and they have a chronic risk, if they've got any kind of comorbid condition, they recommend Prevnar 13 and then Pneumovax 23. The problem with that is Prevnar 13 is actually not indicated between the ages of 19 and 49. So that would technically be an off-label use. So a lot of organization policies actually just give Pneumovax for that patient, for those patients.
Okay. So should I investigate that someone's got a Prevnar 13 before I give them that shot?
You can ask them, yes. In terms of how much they can get in their lifetime, it's recommended that they don't receive more than 1 dose of Prevnar 13. That's just a single dose. You can have up to 3 Pneumovax doses within your lifetime. And that's across the board for all patients. Any further questions? We'll also have cases at the end, and if we have any further questions, we can delve into that. It's quite a lot of material. Here's a table from the pharmacist letter that puts it more into a word format. If they've had no history of pneumococcal, or if they have an unknown history, you give them Prevnar 13 and then Pneumovax 23 12 months afterwards. If they've got Pneumovax after their 65th birthday, you give them Prevnar 13 as long as it's been more than a year since that dose, and then they don't need revaccination. If they got Pneumovax 23 before 65, you give them Prevnar 13 now, as long as it's been a year since that dose, and then revaccinate 6 to 12 months later if they have any kind of comorbid indication for revaccination. So the guidelines used to be, it's almost like they wedged the Prevnar 13 right in the middle of that 5-year window. So that's how I think about it. But the way I think about things is pretty weird. So, so here's some of the supporting evidence that was used. The CAPITA trial was a community-acquired pneumonia trial in adults. This was conducted by Pfizer. It involved 85,000 adults aged 65 years or older, and it was conducted across 15 hospitals in the Netherlands. So it was conducted for a 5-year period between 2008 and 2013, and it was looking at Prevnar 13 vaccinated adults versus placebo. And they wanted to see the primary outcome was prevention of vaccine-type community-acquired pneumonia. And also they were looking at non-bacteremic, non-invasive cases, as well as for the more severe form of invasive pneumococcal disease. So what they saw was a almost 46% reduction in the primary objective. In terms of non-bacteremic, non-invasive cases, they saw 45% reduction, and also 75% reduction in severe cases. And this was all for vaccine type pneumonia. So all the types that were covered in Prevnar 13 were the strains that they were looking at. And actually for this study, Pfizer developed a specific assay just to be able to isolate what strains were caused by the pneumonia, and they would be able to find out which ones were the vaccine type and which ones were not. And this data, along with a couple of other trials that Pfizer conducted, was used to develop the new ACIP guidelines. Prior to this, there wasn't much data in terms of 65 and older. A lot of the data looked at trials in children and prevention of pneumococcal disease in that population. This was one of the first extensive trials that looked at patients 65 years and older, which is what compelled them to change the guidelines. So kind of switching up diseases a little bit. So meningitis is meningococcal is a new vaccine you can give in New York State. It's typically caused by Neisseria meningitis or meningococcus, and this is a common pathogen for a lot of these types of cases. Up to 10% of people in the United States are actually carriers for this strain. It typically resides in the back of the nose, back of the throat, and typically kind of similar to MRSA. Some patients actually have MRSA within the nares of the nose, so it's a similar mechanism for that. It's spread commonly through contact with respiratory and oral secretions, so in saliva, mucus, any kind of droplets. Living in close quarters are some of the risk factors for meningitis. And as you may have heard in the news, some college campuses actually have had some outbreaks of meningitis in the past. So infants, teenagers, young adults, the ages 16 to 21 are at most risk. First-year college students. The reason why they mention first-year college students is some of the college students aren't caught up with their immunization at the age of 18 yet. So when you're living in close quarters, especially in a dorm room, I mean, it wasn't a couple of years ago that I was in the same boat, that you're in close contact, sharing utensils, sharing plates, that can cause for a bigger risk of contamination, as well as for other types of diseases. Traveling to sub-Saharan Africa, there's an area of Africa known as a meningitis belt, and some of the pilgrimages for the Muslims during the holidays, they go what is known as a Hajj, and during that time there are millions of religious people within that area of Africa. So any person traveling during this time is actually recommended to get vaccination before leaving the country. And another one that isn't as common is asplenia. It doesn't mean that you don't have a spleen. Some patients actually do have a spleen, but it isn't functional, depending on injury, any kind of other condition that could inhibit that, and those patients are also at risk for meningitis. Some of the symptoms, nausea, vomiting, fever, it's typical across most diseases. What's I guess common for meningitis is neck stiffness and photophobia. Some patients actually may have confusion or altered mental status. The meninges around the brain gets inflamed, it can cause compression and long-term damage. And what you're seeing here is, this is called the tumbler test. So another telltale symptom that I actually didn't put on here was a rash. Some patients actually get a rash during meningitis. So what they do is they take a clear glass or some sort of tumbler, they press it against these type of little erythema spots, and if that blood doesn't dissipate, it's a sign that it could be meningitis. This isn't a definitive diagnosis. As pharmacists, we wouldn't diagnose, but if some patient has maybe perhaps tried this test, it's kind of like an old wives' tale. If, obviously recommending them to see an urgent care physician or perhaps going to the ER is the best recommendation. But I thought it'd be an interesting little FYI. So some statistics about meningitis: about 10 to 15% of cases result in death despite treatment. Some up to 20% of cases actually can result in loss of limb, deafness, or even damage to the brain or nervous system. As you would expect, if it's left untreated, the inflammation of the brain can cause some long-term complications. There are two types of vaccines available for meningitis. There's polysaccharide and conjugate vaccines. The difference between the conjugate and polysaccharide is basically how the vaccine is constructed. And actually the pneumonia vaccines are also a conjugate and polysaccharide as well. The biggest difference between the two is conjugate vaccines take the shell around the bacteria and they isolate it, and they get that to make the immune response, and then they add in a conjugate to that protein from usually diphtheria or tetanus to build a stronger immune response. So conjugate vaccines are actually better because they provide a stronger immune response. The disadvantage is that they're costly, they're more expensive to produce, and not all vaccines come in that form. Polysaccharide vaccines have been around for decades, they're tried and true. The problem is for children under the age of 2, they're not as effective because the immune system isn't strong enough at that age yet to develop it. It's a little interesting tidbit. So the first meningitis vaccine to discuss is Menimmune. Menimmune was approved in 1981. It was one of the first meningitis vaccines approved in the United States by Sanofi Pasteur, and it's indicated for 2 years and older, and it covers 4 strains, ACYW-135. Don't know why that one got a number, but well, maybe they felt a little numerical. It is the only meningitis vaccine indicated for ages above 55. Every other meningitis vaccine has an age restriction. This is the only one you can use for patients older than that age, older than 55. So it comes in a vial, has to be reconstituted, and it's given subcutaneously. It can be single dose, must be given immediately. There are also a multi-dose vial available, and it can be used within 35 days if it's kept refrigerated, but obviously the quicker to use it as long as you keep it refrigerated. And it's also a 0.5 ml dose. Everybody loves a 0.5 ml dose. You should never give this vaccine intramuscularly. So Menactra is another vaccine that was approved by Sanofi Pasteur, and this is indicated for 9 months up to 55 years. Covers the same 4 strains, and there's a booster schedule for patients under the age of 15. So if they're 9 to 23 months, they get 2 shots 3 months apart. And for ages 15 to 55, they actually recommend a single dose for this population. If they're at risk, if they're traveling to an endemic region where meningitis is locally there, or if they have any kind of functional risk factor, they can get another booster 5 years after their first dose. But they only recommend it for at-risk populations. It's not recommended routinely. So it also comes as a single dose vial given intramuscularly. Must be drawn up in a syringe. It does not come in a pre-filled syringe. And included is a picture of what it looks like. So Menvio is indicated for 2 months to 55 years. It's another meningitis vaccine, covers the same 4 strains. It's available as a single dose for ages 2 through 55. And as a package, it comes in a little kit that can be used. It's also 0.5 ml, single dose. Seeing a pattern here. Single dose given intramuscularly. It comes in 2 vials. They have to be combined to be reconstituted. And ideally, it should be given immediately. However, if you have a patient that comes in, they want to get it, but then they disappear, they go out shopping, or whatever reason, it can be stored up to 8 hours at room temperature or at refrigeration. And as well as with the other vaccines, should never be given sub-Q or IV, but I don't know how you would do that. So here's a new vaccine. This is actually just approved, and I actually had to update the slides last week just to include this. This is a vaccine, Trumemba. It was created by Pfizer. It was approved actually on October 29th, a couple of weeks ago. And it got an accelerated approval for vaccine type B. This is the first vaccine approved within the United States for strain B meningitis vaccine. And I don't know if you've heard, but there were a couple of outbreaks in Princeton University, as well as out in, I believe, San Diego in California, college campuses. There was a meningitis outbreak. About 30 to 40 students were affected by it. And strain B was one of the common strains for this outbreak. In Europe, as well as in Canada, there have been vaccines approved for vaccine strain B. The FDA had not approved it for a long time. And because of those outbreaks, they gave this one a fast-track approval. It's indicated for ages of 10 to 25 years, and is a 3-dose series given 2, 4, and 6 months apart. And how I would remember this is, think Trumemba. It's a true vaccine for meningitis B. That's how you can remember it. A little credit to Mr. Flynn for giving me that little See, I never forget those things in pharmacy school. So in terms of ACIP, they recommend routine vaccination patients age 11 through 18 years, especially for college students. And of course, the same at-risk populations are listed there. Military recruits and anyone who's exposed to patients with meningitis or in their workplace are also at risk for developing the disease. And of course, endemic regions where patients are traveling to are also a risk factor. So shingles, I'm not going to spend too much time on this, but basically it's been drilled into our heads. Everybody knows shingles, everybody gets scared. The pictures, you've seen them. I didn't include them in here. I didn't want anybody to have any adverse reaction to breakfast. So I'll spare you that, but 1 in 3 people will develop shingles. Annually, 1 million cases are seen within the United States. And of course, at-risk population, the biggest risk factor is if you've had chickenpox as a child, that can lay dormant within the nervous system and be reactivated at a later point in your life. 50% of cases are in patients 60 years or older. So as you can see here, it's a rash that develops on usually one-sided on the face, shoulder, and trunk, and it usually travels along the nerve. Usually you can see on the face, it's unilateral or on one side, go around the trunk, and it can be very painful. It's associated with a lot of nerve pain, and some of these the rashes can blister, cause scab, can cause also a lot of adverse effects for the patient. Fever, nausea, headache, as you would see with a lot of other infections, and unfortunately there are long-term complications with shingles. Some patients may have what's known as post-herpetic neuralgia, and it's not the type of pain that you can just take ibuprofen and be done with it. It's very persistent and can be very severe. So very important for patients at risk of shingles to make sure that they get vaccinated. So Zostavax is the only vaccination approved for shingles vaccine in the United States. You can give antiviral medication, valcyclovir is a treatment option for an active case. However, the best way of treating or at least preventing the disease is through vaccination. And there are analgesics and topical lotions that can minimize pain. Of course, there's a lot of persistent pain with that. So Zostavax is indicated for 50 years and older. It's not meant for treatment of the disease, but it can actually reduce the risk of a further outbreak. So you may get patients in the pharmacy that ask, I've already got the shingles, why should I get this shot? Or spend this much money to get the shot? It can reduce the risk of getting a further outbreak, or at least the severity of it. It's not indicated for active treatment, but lost my train of thought there. I don't know what happened. Guess I didn't get enough coffee. It's applied as a single dose. It's unique in that it's frozen. It has to be reconstituted before administration. It's given as 0.65 mils subcutaneously, and it is a live vaccine. So one of the things with this vaccine is it has to be used within 30 minutes of reconstitution. So you have to be sure that the patient is willing to get it, the prescription is there, and it's fully billed before reconstituting it. Once you reconstitute it, it has to be given right there and then. And one of the problems is if there's an insurance issue, something happens, the patient leaves, that's almost $200 per vial out of the window. So definitely, you don't want to hurt your bottom line, one of the community pharmacies here. And one of the old points for Zostavax is, especially when you're reconstituting it, you have to be very careful not to push it too fast. So when you withdraw the diluent, you put it into the vial, you almost have to kind of let it glide along the side of the vial and then slowly let it dissolve. If you do it too fast, it can cause bubbles to form. And if you agitate it too much or vigorously, it can also cause bubbles to form. It can affect the administration. They always teach you in school to avoid the air bubbles. So ACIP recommends patients over the age of 60 to receive the shingles vaccine. Even though it's indicated for above 50, a lot of insurance companies don't cover it until they turn 60. So it's also a little discrepancy between the two. There is some talk of changing it, the recommendation, so that there is a booster. As of right now, ACIP met in 2014 and they decided there isn't enough data to change the guidelines, but there may be a possibility in the future. They're going to meet again in 2018 to see if they need to revise the guidelines or not. Basically, the premise is there was some trial data that looked at the levels of antibodies to varicella and that they decreased over time, and the immune response beyond 5 years is uncertain. So as of right now, nothing has changed. If any patient comes in the pharmacy, they have questions on that. But just to keep your eyes open and be cognizant of any updates that come from that. So influenza, everyone's familiar with flu shots, flu vaccine. We're in the brunt of flu season right now. So it's a little bit of background. It's caused by the influenza virus. I put a little picture on here. Kind of shows the hemoglobin and neuraminidase receptors. So this is where the H1, N1, all those different receptors come in. The different numbers correspond to different strains. And up to 5–10% of adults are affected every year. Almost 20–30% of children are affected by the flu. And of course, there's also an economic impact to the flu. Time lost from work, productivity lost, as well as increased risk, increased burden on the healthcare system. That's why vaccination is so important. So of course, children younger than the age of 2, adults over the age of 65 are greatest risk for influenza, and of course complications arising from it. Pregnant women, they actually do recommend vaccination of pregnant women. Of course, they cannot receive a live vaccine, so the only flu vaccine they can't receive is the intranasal, since that's a live vaccine. They do recommend routine flu vaccination for pregnant women. Any patients with chronic disease and diabetes, heart disease, asthma, COPD, these patients are at increased risk for long-term complications. And pretty much any unvaccinated child or adult. It's good to reduce the transmission of this disease, and important to recommend vaccination across the board, as long as they don't have egg allergy. There's only one vaccine that doesn't have egg allergy. Influenza symptoms: fever, chills, cough, cold. Feel like you got hit by a truck for a couple of days, and you don't want to do anything. Definitely not something that you want to experience. You want to avoid it at all costs, especially for the elderly population. The vaccination is the best prevention. There are different types of flu vaccines available in the market now. Intranasal and intradermal are two of the newer ones. And this year we've had the Quadrivalent Vaccine. So these have 4 strains of the flu virus in it versus 3 in the older ones. There's a high-dose flu vaccine, which has been marketed heavily over the last couple of years. Then there's the egg-free recombinant vaccine. This is known as FluBlock. This is fairly new to the market. It doesn't use egg particles to incubate the virus. However, it uses a recombinant technology similar to how insulin and those type of drugs are produced. It's very expensive. It's not always covered by insurance. However, it is an option for patients who have a true egg allergy. So that means anaphylactic swelling hive type of reaction. So these are the type of quadrivalent vaccines available: Fluarix, Fluzone, Sanofi Pasteur, and FluMist. The intranasal is now quadrivalent. I changed it for this year. And one thing to be careful about is the different ages for these vaccines. So as you can see, Fluarix is only for 3 and older. Fluzone actually can go down to 6 months and older. Of course, as pharmacists in New York, we can't immunize anyone under the age of 18. But in the past, Governor Cuomo has signed emergency orders to allow us to do that for pediatrics. So always make sure, if that is the case, that you double check the ages on the vaccine. And as you can see, the intradermal is actually only indicated for 18 to 64. So there are different age ranges that we should be cognizant of.
I read yesterday, 2 days ago on the news, I heard where the intranasal vaccine is not working on kids.
Mm-hmm.
The
Anybody heard that?
CDC,
Yeah, it didn't work on H1N1 last year, and the kids,
the CDC changed their recommendations. The only preference they give is for ages 2 through 8 that they get the intranasal vaccine. I mean, I didn't read that article, and I didn't have a chance to read it, but past couple of days.
yeah.
Well, it is a live vaccine, and it also depends on the administration technique. I haven't really seen it in practice. I think it's more of something that the doctor's offices use. But if they have any kind of contraindication, like asthma or something, they shouldn't receive the vaccine. Personally, I prefer the tried and true intramuscular, but maybe I'm old-fashioned. The high-dose vaccine is indicated for ages 65 and older. It's been a huge marketing push. A lot of seniors and older patients come into the pharmacy, ask about high dose. ACIP and the CDC does not have a preference as to which vaccine you should give 65 and older. So in the pharmacy, what we've seen is a back order on the high dose. Because of Ebola, because of all the the media put behind it, a lot of patients are very scared. They've come and get the high dose, and now there's a huge shortage on it. So the question is, if a patient comes into the pharmacy, you don't have high dose, what do you give them? You can actually give them quadrivalent. It's better to give them a flu vaccine rather than none at all. Some patients may express a little bit of hesitance towards that, but there's no official preference for high dose over the regular flu shot for older patients. So I found that pretty interesting. I've had this question a couple of times in the pharmacy and did some research, and this is one of the answers, recommendations I came across. High dose is still trivalent. Sanofi is going to switch their entire product line to quadrivalent within the next year. As of right now, it still only has 3 strains in it. So FluMist is given intranasally. There's a little kid getting his flu shot. He's very happy, I'm sure, that he doesn't have to get a needle. 0.2 mils, so it's 0.1 in each nostril. It comes in as a pre-filled nasal spray, and it has a dose divider clip on it that stops you for the first dose. You remove it, and then you administer it in the second nostril, and it's kept in the refrigerator as most vaccines are. And here's a little administration technique. I know you probably haven't seen this, but You remove the rubber tip, then it exposes the nasal spray. Make sure the patient is upright so that they're not tilting their head back or forward. It's perfectly perpendicular. You push it with a little bit of force. So you have to spray it really well, otherwise you don't get the entire dose out and it doesn't mist properly. And then once it stops, you remove the dose divider clip and administer it in the second nostril. So fairly quick administration, very easy to use, and it also does not require any injection or needles, so kids like it a lot. So as you can see, it goes into the nose and cause some nasal side effects, runny nose, congestion, can cause some stinging sensation. Some patients may get a fever afterwards, and then sore throat and sort of postnasal drip. However, these are normal. It's only indicated for ages 2 through 49, and if they have any respiratory condition like asthma, COPD, a history of allergy, they cannot have this vaccine. And another thing is that since it is live, it is not recommended in pregnant patients or patients with severe immunocompromise. And of course, with this vaccine, you still have the risk of the egg allergy. It's not egg-free, so if you have a patient with a true egg allergy, also make sure that you counsel them on that. So as mentioned earlier, another contraindication is concomitant aspirin use. This is basically because of the risk of Raynaud's syndrome in children and adolescents. It's also pregnant women, severely immunocompromised, and history of asthma, stated earlier. So here's the intradermal vaccine. This is approved for 18 to 64 years of age. The needle is very small. It is literally the thickness of a penny. So if you have a penny, you can actually see how thin the needle is. It's 0.1 mils given intradermal, pre-filled retractable syringe, and this is also still trivalent, though they are going to convert this to the quadrivalent within the next year. So I actually have a kit that I can pass around later if you want to take a look at it, but this is what the intradermal looks like. Get that out of there. So it comes in a pre-filled syringe like this. Where did I cut my nails? That looks pretty for presentation. So it comes in a syringe like this. So before you administer, obviously you wipe their arm. It goes into the upper deltoid region, just like the regular flu shot. You almost hold it like a pencil. So have your index, your thumb, and your middle finger kind of holding the barrel like this. And there's notches there for administration. And you have your index finger on the plunger like so. So then you press it against, without too much force, on the deltoid area. So you want to make sure that you don't indent on the skin. It's actually, you just have to lightly press against it. And then you remove the needle, as you can see here. And then I have a little demo kit. I don't have to inject myself. So you press against like so, and only need a light press. You don't want to jab it in like that because that can cause a lot of pain for the patient. Once that's in the skin, you press, you remove it, point it away from you, and then it's kind of hard to press this, but I always do it like that. The retractable syringe activates, now you reduce risk of a needle stick. So a lot of pharmacists actually don't like using this. I like it because you don't have to add to syringe and it's actually kind of quick. Problem is, since it is intradermal, it doesn't go as deep into the muscle, so it can hang around in the dermal area. It can cause a bubble to form, and some patients may actually have a redness reaction to it. It kind of looks like a mosquito bite, it may be warm, red to the touch. That's normal. It usually dissipates within 1 to 2 days. So it's less pain that persists, it's more pain up front, and then some patients may have that reaction. And of course, you click, activate the retractable syringe, and reduce risk of needle stick. So last but not least, Ebola. What is going on in the world today? What's going on in the United States? So Ebola is a hemorrhagic fever that was discovered in 1976 in the Republic of Congo by a team of researchers. It's caused by the Ebola virus. There are 4 strains of it that can cause infection in humans. There is a 5th strain, but that only is active in monkeys. Ebola Zaire is the strain that is in the outbreak currently. And there's a picture of the menacing virus. So the symptoms of Ebola in the initial stages mimic the flu. So you get fever, chills, malaise, fatigue, just run-of-the-mill flu-like symptoms, which is why it's kind of hard to diagnose it. In later stages, it can lead to diarrhea, nausea, and vomiting. And in the final, most severe stage, it can cause hemorrhagic fever and fluid loss. That stage is actually not for every patient. It's a misconception that every single Ebola case will result in you bleeding profusely to death. That is a misnomer. Actually, only about 20% of cases can result in that severe form, as long as they have adequate care. Now, of course, in Africa and also endemic regions, healthcare systems are not as robust, and that's why we can't manage those patients effectively. But with good care, you wouldn't see that most of the time. Ebola is only transmitted through direct contact with bodily fluids. It is not airborne in the traditional sense, and has an incubation of 2 to 21 days. As you've seen with the cases in the US, the CDC has monitored these patients. Actually, Texas has just been declared Ebola-free. All the contacts for the 3 cases that were in Texas have been cleared. So, you know, it's not as transmissible as the media would like you to believe. It is actually, with good precautions, actually hard to transmit. There's limited evidence for cough and sneezing transmission, though there is a caution with respiratory secretions. The 2 nurses that were taking care of Tim Duncan, they were taking care of him towards the very end stage of his disease. They actually were not able to diagnose him in time. So the theory is that as the disease progresses, the viral load increases in the body, and it becomes more and more infectious. So as you noticed, none of his family members, none of the people living in his apartment complex actually became infected with Ebola. The 2 healthcare workers were the only ones at the very end before he died. So with adequate personal protective equipment, with good precautions, the CDC just revised their protocols for isolation, they should minimize, almost reduce the risk of transmission. It does not survive that long outside of the body. It's killed very easily through hospital-grade disinfectants. So, of course, with isolation, you want to make sure if there is any bodily fluids present that they're cleaned up effectively and in a timely fashion so that no one who's not wearing adequate gear can be infected. So Ebola is diagnosed obviously through a laboratory test. It can take up to 12 hours to get. They were developing a rapid test for it to reduce the time frame for diagnosis. But the key and the most crucial piece of information is travel history. If a patient comes into the pharmacy or you're in an urgent care clinic and they have the symptoms of flu, they've got the flu-like symptoms, they feel that they've got the heavy cold, ask them where their travel history was. This is a key to diagnosing it. If that hospital, not to criticize them in any way, but if they had asked what his travel history was and taken that into account before discharging him on just simple antibiotics, they could have perhaps changed the entire course of his disease and perhaps could have saved his life. However, this was the first case for them. It was the first case in the United States. It's understandable now that the procedures have changed, the protocols have been revised, but always make sure that you ask for travel history. And actually, in a lot of the physician offices that I've visited over the last couple of weeks, just for detailing, notice that they have signs up now, indicate your travel history before even going in to see the doctor. So it's very important that you ask that.
I believe actually the nurse did ask.
Oh, did the nurse ask?
The nurse asked, and her notes didn't get transferred over to the doctor.
There was a lot of details that they weren't releasing about that entire case.
I heard that too.
Looked very sketchy to me. And then they actually went back and retracted the story that they sent originally and then changed it and changed some of the details. So it just goes to show it's important to have all your procedures in place before, and perhaps, we weren't as prepared as it was originally as we should have been, but the case in New York City at Bellevue Hospital for that one doctor who came back, he also is just cleared as well. So I think we've got it down to a science now. So as of November 2nd, the statistics are a little outdated, but the total number of cases is 13,000. We've seen about 5,000 cases who have died to the disease worldwide. The cases are most concentrated in Liberia, Sierra Leone, they're pretty hard hit, and of course Guinea. And actually, within the last couple of days, I read an article about a possible Ebola case in Mali, in the country right over the border. There was a toddler who had Ebola, and unfortunately, they did not identify in time. She went through a traditional burial process, so they embalmed the body, they had contact with the body. There's concern that there may be potential contacts out there. So there hasn't been any updates in the news as of yet, but we may see some more cases within Africa. There are 4 cases, new cases within the United States, not including the ones that the patients we flew back from Africa. Tim Duncan was the only death. The 2 nurses, as well as the doctor, all of them which made a full recovery.
There's a 1 chemist today.
Yes, one patient came into
Couple of patients.
Omaha, in Nebraska. He is actually in pretty critical condition, so they're a bit concerned about his prognosis. However, it's been a couple of weeks since they had the last patient, so they said they're confident that they can treat him, but that is one of the, I believe, the 4 hospitals that are federally certified to deal with Ebola, so hopefully they have it down pat there. Here's a map that shows the severity of cases. The darker the color, the more severe, the more prevalent the cases are. As you can see, they're very concentrated in Sierra Leone and Liberia, and have spread through Guinea and Mali. Nigeria actually had, I believe, only 8 or 10 cases, but all of those cases have resolved, and the World Health Organization declared Nigeria Ebola-free. So there is progress being made. Liberia also revised their burial process. They can now identify bodies within 24 hours and have cut down the lag time between the time a patient is declared dead from Ebola to the time they're buried. So it's minimizing that time for family members to have contact with the body and traditional burial processes. So what's the Ebola impact in pharmacy? So if a patient comes in with acute signs, with the flu-like symptoms, always check travel history and practice good hygiene, hand washing techniques, making sure anything that's contaminated is properly disposed of, as well as utilizing personal protective equipment if a patient is in isolation. And also making sure that you review protocols. In a community pharmacy, I mean, you're not going to be walking around with a hazmat suit, obviously, but just making sure that you have adequate protections in place, especially if you work in a clinical setting. And also advise patients to receive their flu vaccine. Since Ebola does mimic flu in the early stages, it'd be good to know that if they had a flu vaccine in the past, it most likely could be something else. It's just a little piece of information just to isolate and remove some other diagnoses. That way you can effectively triage a patient. But some of the Ebola myths, as mentioned earlier, not every case results in profuse bleeding. It's not airborne in the traditional sense, and mortality is less in developed healthcare systems. As you've seen, every case since the first Ebola case has fully recovered. There was the doctor who came back who received the experimental Ebola vaccine serum, as well as the other missionary worker, I believe, and a couple of other people who came back from West Africa. And it's only transmitted through direct contact with bodily fluids. Bodily fluids, blood, respiratory secretions, especially during the last stages, any kind of bedpan, diarrhea, vomiting, those are the types of fluids that can cause infection. All right, so with that being said, we're going to break up into groups. I've put cases up on the tables here. So there's 5 cases total and a couple of questions per case. So we're going to give about like 10 minutes or so just to read the cases and answer the questions and talk amongst yourselves, and then we'll review all.
We all understand.
I didn't get one. Where'd you get it from?
I think we're sharing it.
Yeah.
We can share it.
Okay.
I think we're the same. Yeah.
All right, so for the first case, it's that time of year again. Santa Claus is preparing for his busiest days of the year. The North Pole's busy as ever. Elves are busy pushing the presents through product dispensing. Santa's trying his best to verify accurately and efficiently. Inevitably, some of the presents enter the adjudication queue if they misbehave, and are replaced with lumps of coal. All this grueling work has Santa concerned about his health, so he approaches your pharmacy counter and inquires about the flu vaccine. He acknowledges he's not as young as he once was. Was he ever young? Don't know. And he wants to be protected this holiday season. Santa mentions that your presents are in the adjudication pile and that he will DUR override them if you can recommend a vaccine that isn't painful. So which flu vaccines would you recommend to Santa to minimize pain? I think that's that case one.
You've got the answer.
You don't mind, I mean, not knowing his age, you can do DNA or experiment.
Yep, that's exactly it. So those are the 2 vaccines that would minimize the pain. I kind of just made it that he was older than 65, but I didn't want to give the number in there to make it a little bit more difficult, even though these are fairly easy. But my first time creating these type of things, so.
Yeah, most Santas are 65.
I don't know. I mean, he's always been like that. He's just kind of like stayed that way his whole life. All right. So the next question: Santa seems very interested in the Fluzone Intradermal vaccine. Needle's very thin. He likes the idea of relatively pain-free. You want to get your presents out of adjudication, so you consider administering the intradermal shot. Is this a good recommendation for Santa? Why or why not?
Well, if he's too old, you know, to do that, like 49 or something.
Yeah. 64 is the cutoff for intradermal. So 18 to 64 would be the age, and for the purposes of this exercise, you can assume Santa's over 65. I probably should have put that in there initially, but yes, so intradermal would not be, it would be an off-label use for him. So next question, it's approaching closing time, Santa's still not made his decision. He asked about the high-dose vaccine for 65 and older. Unfortunately, you mentioned not having any stock within the pharmacy. He intently stares at you while the sweat begins to form across your forehead. Your presents are still in the adjudication file. Can Santa still receive the quadrivalent vaccine? Exactly. The answer is yes. ACIP does not have any preference over which vaccine you give for 65 and older, so you can give the regular flu shot. So you administer the vaccine painlessly, and Santa's incredibly impressed with your pharmaceutical care. How long will it take to build full immunity to the virus, or at least a typical time frame? 2 to 3 weeks. Yep, exactly. And that's what I always regurgitate, so it's ingrained into my mind. So 2 to 3 weeks is what's on average to build full immunity to the virus. Some people may do it faster, some people may take longer. It all depends on their body and what their immune system is. And what are some of the common side effects that you experience for the regular flu shot? Sore muscle, yep. Soreness in the injection site reactions. Some patients may complain about the flu-like symptoms, or they got the flu from the flu shot. Obviously that's not true, but it could just be their immune system that's building up response, and everybody's obviously very different. So very good. All right, case 2. So you are closing up the pharmacy for the night after a long night during the holiday season. It's been very difficult. You just spent the last hour counseling Santa Claus on the flu vaccine and managed to painlessly administer the vaccine. He was so impressed with your technique, he invites you on a sleigh ride to help spread holiday joy. While traversing the countryside, Santa parks the sleigh on a rooftop, and in holiday tradition, climbs down the chimney discreetly. Unfortunately, the holiday season is quite festive, and Santa is being stuck in the chimney. Rudolph makes a quip about the need for dietary counseling, and while rolling his eyes, he attempts to free Santa. Santa begins to wonder about the years of inhaling all that chimney smoke and having to use the pro-air HFA more often in recent years. You determine that he has never received any pneumonia vaccine in the past. Which pneumonia vaccine would be recommended initially?
Oh, it was at the empty chair, so I took it.
Oh, you took it? Oh.
So,
I can.
am I the only one that did case 2?
Are
you all done? Okay, well you go ahead, because I also had case 3. I just did this for extra.
For fun.
No extra credit is offered to you.
I know.
Only 1.5.
So you guys can go.
We said Prevnar 13.
Yep, Prevnar 13 would be recommended initially. That's exactly correct. Because he's never had any pneumonia vaccine in the past, so you give Prevnar 13 right away. Would Santa have any subsequent vaccines for pneumonia as per guidelines?
For guidelines, yes. Pneumovax.
Yep, exactly. So you get Pneumovax 23. And can they be given at the same visit, Prevnar and Pneumovax?
No.
Exactly. So what would be an acceptable time frame?
At least 8 weeks, but 6 to 12 months.
Exactly. You guys are really paying attention.
We
I
listen.
wonder what's going on over there. They must be eating. So here's an interesting question. The discussion jogged Santa's memory a bit, and now he mentions receiving the old PCV7, that was known as Prevnar, vaccine in the early 2000s. Would he still be eligible to receive the pneumonia vaccine today?
Yes.
Yes. And actually, this is a question that I got in the pharmacy practice. We had a couple of patients who came in. They had this old PCV7 vaccine, and they were asking, the pharmacist had a question as to whether she should give the vaccine or not. I did a lot of research. I tried to look at the CDC, the ACIP guidelines. They do not mention the older vaccine at all. So you could read, and this actually was an off-label use. PCV7 was only for children up to the age of 5. I'm not exactly sure why these patients got it after that age, but you can give Prevnar. It covers more strains, it's more efficacious, and is the current recommendations, and you'd be sure on that. And if you had any doubts, you can always ask the primary care doctor. So Mrs. Claus calls Santa and scolds him for coming stuck in the chimney. Santa throws you the phone in frustration as she has some questions for the pharmacist. You can't just catch a break tonight. Mrs. Claus received a Pneumovax 23 before the age of 65 many, many years ago, and would like to know if she needs a booster. Which vaccine would you recommend? Prevnar 13. So it's been more than a year since she received it. She can get Prevnar right away. And would she need any subsequent vaccinations?
She could do Pneumovax in 64.
Exactly.